It's my pleasure to be here today on behalf of the District Health Board's Chief Executives to launch the first of the mental health and addiction quality improvement projects, Zero Seclusion, towards eliminating seclusion by 2020. So I'm going to talk a little more about what that means. But a little bit of background: the District Health Boards were drivers behind the establishment of the Mental Health and Addiction Quality Improvement Program. This came about because a number of the leaders in the sector expressed concern that the services seemed to be working in an environment that impeded the normal processes for review and improvement when there were serious adverse events. There was also a significant amount of criticism of services and of health professionals by the public. To improve services, the DHBCEs were asked to support a dedicated mental health and addiction quality improvement program to be led by the Health Quality and Safety Commission and to be based on the collaborative methodology similar to the Scottish Patient Safety Program and the IHI. The DHBCs shared the concerns expressed and decided to fund the Commission for 5 years to lead the program. Zero Seclusion towards 2020 is the first of the initiatives and that will be led by the Commission over the next few years. The others are improving service transitions, and that's due to start in a few months, learning from serious events and consumer experience, maximising physical health, and improving medication management and prescribing. These 5 priorities were identified through consultation with the sector and the mental health consumers and family and whānau, and importantly have bodies of evidence that show that significant improvement can be made. I think you'll agree that getting these 5 right will dramatically improve the service delivery. So, aspirational goals. So zero seclusion by 2020. That's challenging, sure is. Aspirational, sure is. Controversial, perhaps, probably is. In my experience and the experience of many of the others, both nationally and internationally, aspirational goals can be an important tool for achieving transformational change. To go big, you have to think big. And we're thinking big this time. The bigness of the idea gives it a motivating power. Not many people are inspired to give their precious time, energy and resources to maintain the status quo. Setting a bold and aspirational goal provides an inspiration that generates motivation, resources and a new sense of what is possible. Of course, aspirational goals will only succeed if they reflect people's own ideas, hopes and aspirations. And those who work in mental health and addiction services, those that use the services, and indeed successive governments have long had a commitment to reducing and eliminating seclusion. And we have made good progress over the last few years, thanks to the support that we've had from TPO and the National Mental Health and Addiction KPI program and the efforts of frontline staff. But we now have reached a bit of a plateau. And for the last few years, around 10% of people accessing services are still being secluded. There is also an 11-fold variation in seclusion practice across the country. So we do need to do much better. So I see the goal of zero seclusion by 2020 as the big idea, the inspiration that can take us to the next and hopefully final step of the journey. It's certainly a stretch goal, but we as DHBs are used to stretch goals every year when we get the funding envelope. And for the sake of people who use our services and the staff who provide them, we need to put all our efforts into achieving this. So why is zero seclusion so important? It's widely accepted that restrictive practices such as seclusion have a very negative impact on both people subject to seclusion, to staff administering it, and to both consumers and staff who observe it. It contravenes basic human rights and does not align with modern evidence-based quality care. For the people subjected to seclusion, it causes physical and psychological harm. People who have been secluded have used the following words when talking about their experiences: loneliness, fear, anger, sadness, frustration, powerlessness, lack of autonomy, re-traumatization, sensory deprivation, dehumanizing, feelings of humiliation, coercion and punishment. Just goes on. The staff report conflicting feelings and ethical dilemmas. Understandably, they are concerned about safety, both their own and the safety of the service users, and they perceive a tension between providing least restrictive practice and a clinical risk-averse culture. Sounds familiar, doesn't it? So we have to find appropriate and therapeutic ways to better address a number of factors, which include extreme distress, aggression, threats of violence, anxiety or fear of being harmed. However, there is increasing evidence that least restrictive practices do not increase risk to staff safety or increase violent incidents. So the Zero Seclusion Collaborative is a real partnership which provides the Health, Quality and Safety Commission, TPO, DHB's, a National Mental Health and Addiction KPI program. It also incorporates expertise from across the sector, from consumers, family and whānau, and from Māori. I want to talk a little bit about these partners, as each brings a particular set of expertise to the table, and combining these will be critical to achieving our shared aspirational goal. So the Health, Quality and Safety Commission has successfully implemented quality programs across many areas and are very familiar to us. They have considerable experience and expertise in applying quality improvement methodology to its work. In particular, the Commission regularly uses co-design processes and methodology and measures the tools that are needed to make Zero Seclusion National Collaborative successful, and the Commission has gathered together a strong team to lead the program with experts in both mental health and improved methodology. I'm also very pleased the Commission is taking a lead in this, and I personally want to thank Janice and the team for picking up this program, because I think with having the label of the Quality Commission on it, we can see an outcome of improvement, whereas sometimes it's not so easy to see that if it's an imposed program from elsewhere. So I support the initiative, the science, the evidence and the framework. As I mentioned earlier, TPO has been very successful in helping DHBs reduce the use of seclusion since 2009. They guided the sector to an overall 50% reduction in seclusion since 2009, and without their work and expertise, we would be starting this program in a much worse position. TPO has also recently carried out an evidence review that pulls together evidence on strategies and approaches effective approaches in reducing and eliminating seclusion. The ideas in that evidence review will be useful to you all in developing your change ideas as you go through the co-design process. The district health boards are the engine room of this program, designing, implementing the change ideas and measuring the success using the well-tried PDSA program methodology. This will require support from the leadership of each DHB, and my job is to ensure that each DHB leader provides you with support, with resources and commitment to this program. So I see that as part of my role as the lead CE for mental health in New Zealand. The National Mental Health and Addiction program, KPI program is another important partner. The vision of the KPI program is to enable the sector to bring about improvement to consumer outcomes through ready access to and use of comprehensive service performance information. This approach promotes the sharing of information, ideas and learning to drive service improvement. For the Zero Seclusion initiative, the Commission will be building on learning from the National Mental Health and Addiction Program and TPO and developing appropriate measures. I was pleased to see that the Commission has employed a dedicated senior data analyst to lead the measurement work, and you'll be meeting Natalie later today along with Richard from TPO in the session on learning from data and its use and improvement processes. I have deliberately left the involvement of consumers and Māori as partners as an initiative to last, and I'd like to take a closer look at both the role of consumers in this program as well as the importance of taking an equity-based approach. I'd like to acknowledge the consumers who are attending today's event. Your involvement in this program will be critical to its success. A co-design process is an integral part of the Zero Seclusion improvement initiative. It is a process supported by evidence that recognises the importance of engaging consumers in every step, including the design, implementation of improvement processes. I'm pleased to see that Dr. Lynn Mayer will be introducing co-design to the participants later in the day. For those of you who have not been involved in co-design processes before, you have a really stimulating and meaningful time ahead of you. I would also like to acknowledge the presence today of our program Kaumata and his team, members of the mental health and addiction team and Māori members of the project team are here today. There are significant issues around equity of access for Māori, poorer outcomes from the current mental health and addiction system, and Māori confidence in the system is low. No program can claim to be successful if it does not address these issues. This is why the Mental Health and Addiction Improvement Program has a dedicated kaumātua and cultural advisor, as well as a newly formed Māori advisory group. In relation to seclusion, we need to acknowledge that Māori consumers are more likely to be secluded than non-Māori. They are also overrepresented in other restricted practices. For example, in 2015, Māori were 3.3 times more likely than non-Māori to be subject to an inpatient treatment order under the Mental Health Act. I'm pleased to see that the Zero Seclusion program will deliberately include Māori in the co-design and implementation of change. This will involve members of the Māori Advisory Group and, of course, Māori members of the DHB project teams. I understand, too, that there are some concerns in the sector about possible unintended consequences relating to the elimination of seclusion, such as increased use of pharmaceutical restraint, increased use of physical, mechanical restraint, and increased use of observation. Knowing ahead of time what these consequences might be makes them easier to avoid. And this will be an important part of your planning, your initiatives, and developing measures to capture any negative consequences. And of course, there will be positive consequences that will go well beyond the elimination of seclusion. The evidence-based strategies and approaches that will be used in your initiatives. There are also those that lead to better therapeutic communication and improved physical environments, a more caring service that will result in a better mental health and addiction outcome for all consumers, family, whānau and staff. As I mentioned earlier, the desire of the DHB CEs and sector leaders that mental health and addiction quality improvement program be based on the methodology similar to the Scottish Patient Safety Program and IHI. So I'm pleased to see that over the rest of today you will be learning more about that methodology, including the co-design process, how the methodology works, and how to use measurement. Thank you for inviting me to launch this initiative. I'm very passionate about it. I think it's one that we can get collectively over the line. So I'm looking forward to 2020 when we have no seclusion. Thank you.